We are going to start this table with excuse me.
Veronica Jubei.
Veronica
Jubei.
Jubei. Tell your name. Veronica
Jubei, yes.
She's a PhD researcher in philosophy, and she has been working in phenomenology. Okay?
Yes, yes, exactly.
So I pass the word.
Okay. So good morning to everyone. Me and my colleague Valeria Bizzari are going to present our work in the context of phenomenology of depression. And as you can see from the first slide, we are focusing on melancholic depression, the disrupted chiasma, therapy and dialogue through a philosophical approach. So, have you ever felt at the end of the day tremendously exhausted and almost deprived of your bodily energy? At the moment, you try to pinpoint what could have strained you so consistently, recalling in your mind the parts of your day, deals, moments, encounters. And suddenly, a sort of emotional discomfort, an inexplicable feeling of heaviness bursts into your body when you remind to have casually met an old friend in a cafe who seemed extremely distressed, anguished, with something in his glance, postures, and gestures that communicated a whole absence of vitality, a deeply rooted sadness that one cannot easily describe with human words. So intense and pervasive appeared. Then, when you come back home, it is almost as if that friend were still present in your surroundings, tainting the wall of your room with his actual mode of being, enveloping your own presence with his tacit intercorporeal dialogue, composed by his melancholic mood and your bodily receptivity to him. So in our talk, we are not concerned with the neurophysiologic mechanism implied in affective interactions and dialogue, nor with the present presence of mirror neurons in the brain, which, according to the most recent research, seem to represent the basis of human empathy, as you all certainly know. In this presentation, insofar as time concedes us, we would like to focus on a phenomenological aspect of the human body, particularly crucial when it comes to deal with the elaboration of a proper therapy for psychopathological disturbances. The most apparently banal question is, what is the body? Would we be satisfied with the definition of it as a mass of organs, tissues, bones, and skin? Well, partially, at least, especially when we consider it from a medical objectifying standpoint. The Körper, in Husserl's definition, is the object-like thing that occupies a delimited space, the Cartesian res extensa with quantifiable measures. It is the body that I have. From the other side, the body also incarnates a story, a personality, a world of affectivity and narrativity. And from this point of view, the body is life, a unity of perception and movement that inhabits a horizon of significant symbols and interpersonal communities. In Merleau-Ponty's terminology, speaking of the lived, experiencing body is directly correlated with the concept of the flesh of the word. And I quote, "The flesh can capture in itself the elusive schematic presence of the things because it is itself elemental being, self-positing posture, self-moving motion adjusting itself to the roots and levels and the axis of the visible. This intertwining, this chiasm effected across the substance of the flesh is the inaugural event of visibility." End of the quote. The inauguration of the word, its visible disclosure to our life, is mediated by this intertwined dialogic exchange between our body and what is other than me. The flesh, then, is what carries the original trace of the fusion between the subject and the life world. In this fusion, the body represents the primary and spontaneous sense bestowal system of human beings. The double nature of our body, its fluid reversibility of objectifying thing and objectifying medium, for example, when I touch another body, stands for its constitutive relatedness to the foreign. Then the intrinsic chiasm with the life world, conceived as the horizon of multiple possibilities, affordances and encounters, is an essential part of the process of embodiment, happening at the very roots of the subjectivity development. So we are convinced that a crucial feature in the process of becoming a self is represented by its intercorporeal development. It is the nature of the body itself to convey a spontaneous predisposition to the contact with the alterity. From birth on, our life is modulated by affective spaces of interaction, in which pre-reflective persons resonate with each other, experience situation, and feel emotions, often a prelinguistic modality. Think of the mother-child relationship, for example. According to Tellenbach, the mother's irradiating atmosphere is the foundational nucleus of the subjective attunement to the life world. So the body is the most sensitive sounding board in which interpersonal encounters and environmental atmospheres constantly reverberate. So if we manage to overcome the global Western attempt to repress the lived, felt body, fostering the process of technological alienation, we would return to the genuine appreciation of it as the loudest expression of our subjectivity, the core of affectivity, the active contributor of all phenomena, and the perfect seismograph of our emotional life, in Referral's words. So in our account, emotional life is not confined to the mental realm or in the processes that we have to interpret in the others. They are also shared spaces that abide by the intercorporeal dynamics of interaction, happening at the level that we define pre-reflective. So this premise serves us to support and introduce the philosophical setting of a new proposal for therapy and treatment of what in phenomenological psychopathology has been defined a disorder of interaffectivity and intercorporeality. We are referring here to the word of melancholic depression. Depression is the malady of the bodily vital movement, which in normal condition is implicitly oriented towards the future, proactive and interpersonally regulated. In the world of melancholic depression, the person falls into a rigid blockage of its spatial, temporal, and relational dimensions of experience. Everything starts from a gradual devitalization of ordinary daily activities. So patients usually describe depression as a foggy landscape with no colors and sounds, no possibility of interpersonal communication, no space for expansive movements. According to the British writer Andrew Solomon, who himself suffered from a severe condition of depression, when humans are deprived of the most powerful drive for living, which is the capacity of transmitting and feeling affects, then the natural reaction of the body is to contract itself in a painful isolation. So this extinguishing affective capacity freezes the relation with the world and with the others, which, as I claimed several times, is first of all embodied. The person is left with a despairing feeling of complete solitude, carrying on the burden of his body, exhausted, often nauseated, incapable of reacting to smiles, glances, and shakes. The fluidity of the contact with the life world gets lost and fragmented, becoming unnatural and continuously under question, as beautifully depicted by Virginia Woolf in the following extract. Jacob went to the window and stood with his hands in his pockets. There he saw 3 Greeks in kilts, the mass of ships, idle, busy people of the lower classes strolling or stepping out briskly, or falling into groups and gesticulating with their hands. Their lack of concern for him was not the cause of his gloom, but some more profound conviction. It was not that he himself happened to be lonely, but that all people are. So before the appraisal of the individual identity and the continuity of the flow of consciousness, human beings possess an atmospheric sense of being involved with one another. In depression, this tacit dimension, embedded with the everyday being in the world, suffers from a thorough alteration, literally leaving the person in his bed, immersed in a pathetic apathy, a painful absence of pathos that affects the spontaneous tendency of the body to engage in a reciprocal exchange of movements with his environment. So the depressed persons collapse in the abyss of a pervasive silence, oscillating between the hopelessness of a grey future and the memory of a past lived with guilt and grief. Also, they might be hit by panic attacks at a certain time, craving for company and someone to connect with. Using the powerful image of the Latin poet Lucretius, depression can be figured out as a shipwreck with spectator, in which the spectator is the patient who is powerless to the breakdown of his intercorporeal dialogic potentiality, the most essential of which is fluidity through time and space.
So this led us to claim for the centrality of an operative, embodied and affective intentionality which allows the subject to be self-aware and open to the others and the world. This operative pre-reflective intentionality is severely impaired in melancholic depression, where all is crystallized. The body loses its fluidity, becoming heavy and solid, and inhibiting the realization of the subject's intentions. And these disturbances of embodiment in melancholic depression comprise different but intertwined dimensions. The embodied self, so the alteration of the subject's relationship with his own body, the embodied intentionality, which is the alteration of the relationship of the subject with the world. In other words, the alteration of the patient's embodied affective intentionality. Bloyer has defined this disruption as the alteration of the centrifugal functions, that are those functions that connect us with the environment. This disturbance can also appear as a missing of the patient's bodily resonance in the context of an intercorporeal and interaffective dialogue during the diagnostic process. And then we have the embodied time, which is the alteration of biological and existential rhythms. So we can define melancholic depression as a form of alienation from the interpersonal and intercorporeal world. Accordingly, in our view, therapy needs to take into account the aesthetic, pre-verbal dimension of the patient-clinician encounter. Depression does not need only a new definition, which includes the intersubjective openness of the self, but also new therapies, able to grasp the atmospheric instances at play in the clinical situation. The importance of the intersubjective encounter appears to be central already in the diagnostic phase. In fact, clinicians often make the diagnosis of mental disorder within the first 5 minutes of interviewing a patient, which shows the significance of the clinician's intuition. We have not only the precox feeling in schizophrenia, but in 1980, Otto der Zegers and Tellenbach also described the melancholy feeling in depression. Phenomenology as a method plays a crucial role in this process, since it takes into account the intersubjective dimension already at play in diagnostic phase. Minkowski has described this stage very well. It was like 2 melodies being played simultaneously. Although these 2 melodies are as dissonant as can be, a certain balance becomes established between the notes of one and the other, and lets us penetrate a little further into our patient's psyche, end of the quote. According to Minkowski, a successful patient-clinician interaction must prioritize the full understanding of the meaning behind the lived experience of the patient, which goes beyond the casual origin of the illness. From his side, the therapist should first familiarize with the concept of existential stagnation, manifest in the first instance through the kinesthetic paralysis of the patient's body, and from that working on creating a dialogue that gives voice to his painful disconnection from the life world. And the centrality of an empathic attitude emerged in the therapeutic phase as well. The claim that others do not or cannot understand what one is going through features consistently in first-person accounts of depression. Here we have some examples from Radcliffe. It feels like no one else has ever experienced anything like this before, like you are all on your own. And again, however much they say they understand, I don't believe them. The depressed patient not only feels that nobody can understand her, but is also unable to understand the others. There is a break of the relational and intentional attunement with the world. This affects their experience as a whole, and it's very important for the therapist to acknowledge the possibility of profound phenomenological differences. In other words, the interpersonal openness is not only a key feature of the self, but can also be considered as a therapeutic tool when the self seems to lose its chiasmatic relation with the world. Some examples of relational therapies can be the dynamic psychotherapy. In dynamic psychotherapy, a theoretical assumption is that people project representational aspects of important others into a relationship with other people at present. Therefore, interpreting the patient's relationships with other people are key components to enhance change. Then we have the phenomenologically informed psychotherapy, which is characterized by an intersubjective therapeutic space and by the importance of the narration of the experience, so the importance of the biographical context and of first-person reports. Stanghellini and Lysaker pointed out some principles that characterizes the psychotherapy of schizophrenia. We believe that these principles can be applied to depression as well. The principles are the following. The core feature of schizophrenia and depression is the intersubjective disturbances. It's important to achieve a shared partnership as a way of re-establishing a first perspective of one's self-experience, so the importance of a therapeutic empathic dialogue. The therapist should focus on the here and now, so the therapeutic relationship becomes an I-do experience in Buberian terms, and it's helpful to re-establish lost connections between feelings and interpersonal situation. And then the therapy should be able to achieve a shared sense of meaningfulness, that is, to re-establish the link between internal and external narratives. So we have the subjective and also the objective experiences. While clinical psychiatry focuses on the symptoms and uses a descriptive language and an attitude based on the emotional distance between the clinician and the patient who is objectified, phenomenology focuses on the subjective inner experience through which each patient lives her anguish. Interiority becomes synonymous with the horizon of meaning, since the phenomenological perspective adopts a participating, empathic, and active gaze on patient's experience, which is not objectified but fully appreciated in its uniqueness. And a final example is the psychotherapeutic resynchronizing therapy, aimed at creating a gradual readaptation to the common social course of time, by emphasizing repetition and regularity to the structure of the day and the week, and supporting the patient's orientation towards future goals. All of these approaches should have the aim to relax, widen, and mobilize the rigid body. This can happen through music therapy, for instance, or art therapy, or in all of those activities able to overcome the isolation the patient feels within his body. Last but not least, as Fuchs argues, we should not forget that each therapeutic talk implies a bodily level as well. It opens an intercorporeal sphere of pre-reflective body communication that stimulates resonance and, at least for the moment, reduces the restriction the patient feels. It's in this sphere of the intercorporeality and of mutual resonance that recovery and healing for the depressed patient ultimately lie. Of course, this does not mean that pharmacological treatment and neurobiological analysis should be entirely forgotten. Quoting the intervention triangle book, the study of mental disorder must stop over-relying on medication and focus on a more human and person-centered approach to treatment that puts emphasis on the lived experiences of the patients. End of the quote. We believe that the therapeutic intervention supported by the authors can be extremely useful in the treatment of depression. Pharmacology should work together with the neurobiological analysis without forgetting the fact that what is at stake in depression is not a malfunction in brain, but a desynchronization of subjectivity itself and of its synchronic interpersonal and bodily alignment. In this view, the self, the other, and the world are dimensions inextricably linked to one another, to such an extent that we can understand depression only if we take into account their essential intertwinement, and we conceive this pathology as a desynchronized mode of existence. Thank you for your attention.
So, good morning everyone, and welcome again to the 3rd International Mental Health Meeting. So, today I'm talking about the importance of psychomotor observation in a multidisciplinary team, more specific, a case study with Extrapyramidal syndrome and schizophrenia. My presentation will have a description of the case and then a brief theoretical review about psychomotor symptoms in schizophrenia and some features about Extrapyramidal syndrome. And I will end with a reflection about the importance of multidisciplinary work in mental health services. So this case study is about a 37-year-old man nowadays. At the time that I did the evaluation, he was 34. He has a history of schizophrenia psychosis that began after his 20s and a long history of calling up of help, a lot of mental health services like community services, occupational centers, and he was admitted in a day hospital of psychiatry in 2014 with symptoms like cognitive impairment, troubles in his speech, delusions, hallucinations, anxiety, and disorganized thought. And during 2014 and 2015, he participated in the different activities of the day hospital like psychomotricity, psychiatry, psychology, and nursing. But first, I want to talk a little bit about psychomotor symptoms in schizophrenia. So, at the time I did this evaluation, it was during my internship, and I was doing a literature review about psychomotor symptoms in schizophrenia. And I found that slow movements in schizophrenia have been observed since the early 20th century, and both Kraepelin and Wöhler have recognized this phenomenon. So before the introduction of neuroleptics, this phenomenon was already described. But after the introduction of antipsychotics, the attention shifted from negative motor and cognitive symptoms to positive symptoms, resulting in a devaluation in the investigation of the impact and nature of psychomotor slowing in schizophrenia. Understanding the psychomotor symptoms exhibited by patients with schizophrenia might contribute to a better understanding of the disease on its function and social and on the person impact. Because the term psychomotor includes all activities or symptoms in which movement or action are the main component. So includes the planning and programming of the movement and the execution. So not just the cognitive part or the sensory involvement. Psychomotor activities are essential capabilities for adaptive day-to-day activities like dressing, cooking, or driving. So they are key and they are determinant element for functionality, not just in schizophrenia, but for everyone. In my literature of review, I categorized the following symptoms, like extrapyramidal symptoms, like dyskinesia and Parkinsonism walk. And I found studies with patients without medication or before medication. And at the time, they already show these symptoms. So they are not just side effects of medication. Neurological soft signs that are deficits in the coordination of complex motor activities, sensory integration, and cerebral lateralization. Psychomotor slowing. It's the slowing of various motor processes such as gait, fine praxis, speech, and facial expressions. Difficulties in postural control and balance. Time perception diminished or just different. Disturbance in body image and sense of self, because our sense of self, it's because of our body and our perception of our own body. And hypertonia. And the most interesting thing, as I said, is most of the time we see as psychomotor symptoms in schizophrenia just because of the side effects of the medication. But these symptoms are reported as part of the disease. And I think we can all imagine a typical posture of a person with schizophrenia, more tension in the muscles, more retracts, sometimes difficulties in establishing ocular contact. But it's important for me to say this is a typical posture, so not everyone will show these symptoms and this typical posture. So, the case study again. This is a formal evaluation, but I think this isn't needed for what I'm saying next, because for a trained eye of a psychomotor therapist, his psychomotor symptoms were just too obvious. So, this case, on the first evaluation that I did, I observed difficulties on his gait, but not Parkinsonian walk, more like a clumsy gait. Instead of being afraid of touch, of proximity, it was just the opposite. It was a little bit invasive, actually. And I noticed difference in his morphology, like really long arms and long legs for his body. And through the sessions, I observed he had a hyper-extensibility and a really low tonus muscle, but really low. Like, as you can see in the sketch in the middle, he was capable to use his sole of his feet as a table for him to write. During, for example, yoga sessions, he was able to almost put his elbow on the floor. So it was just too evident. And he actually used to have a phrase during the sessions with a smile. He used to say, like, I'm made of Play-Doh. And this made me think, okay, is this an atypical case? Can be. But the low tonus suggested that maybe there is something more here. So I discussed this with my team. We looked in the files and we found nothing, just like he already was doing some psychology during his childhood, but didn't say anything more. And we discussed, and I got lucky because I was listened by my team, because we had a really close articulation between us. And first we thought that will be something wrong with his joints, but then I suggest that this will be more holistic, because it was not just about the hyper-accessibility of his joints, but it was the low tonus that made me think. So, first we tried a referral to neurology, and here was the first obstacle. So neurology didn't find anything. Actually, it said that his abnormal movements was due to side effects of medication, and we are not happy with these reports, and maybe a little bit because of my stubbornness, a little bit because of our close articulation, we decided to continuing following. So we sent him through genetics, and I really remember to say this, even his mother walk is different. And through genetics we found that he had a mutation on FMR1 gene that corresponds to X-fragile syndrome. Okay, and here, just to say, this mutation was just found in 1991, according to my review. Now, X-fragile syndrome. This is the main features of the genetic disease, and here we can see some things, some symptoms that the patient showed. The mental impairment, the phenotypic features, but these dots, I made it after to know the diagnosis from genetics, like the elongated face, prominated forehead, and prominated ears. And here we see the connective tissues anomalies, like the low muscle tones and the hyperextensibility joints, and some behavior abnormalities, like the anxiety, but not the psychiatric diagnosis. So his delusion and hallucinations are one thing, and his genetic disease, it's other thing that answer how he moves, the feature of his body, but one thing is separated from the other. And well, while I was doing this presentation, I thought, okay, I think this is, scientifically speaking, I think this is interesting, but what about the subject? Does this change anything? I believe the redesign of the diagnosis allows an adaptation of the therapeutic goals, because it's very different if we are treating a person with a genetic disorder and with an organic disease. I think too, this might have some impact on his mental health, because we are talking about the 34, 35 years old person who has a disorder that should be diagnosed during his childhood. He just discovered this on his 30s. This might have some impact. This is just my own theory. I don't have any proof of it, but I believe this might have some impact on his development, on his social integration, and this might have some impact on his mental health issues. Okay. So, I think this case is important for a reflection in several points. First of all, talking about my own profession, I think this case highlights the importance of the participation of psychomotor therapies in mental health teams, and the connection between the way the people move and how their mind works between body and psychopathology. And I wanted to bring this because sometimes psychomotor therapists are seen as the therapists who do activities to promote quality of life, or that we work on some specific psychomotor symptoms. But I think that our work in multidisciplinary teams goes beyond that. I think that we can bring a different vision, because for us, we don't separate the body. We don't cut it between head and body. We see the person like he's in a holistic view, body and mind just as one person. And we don't separate into kind of little pieces. And I think this kind of view can be really important in multidisciplinary teams. I think this case of study emphasizes the importance of mental health work being carried out a multidisciplinary team with close articulation between its elements. And not just the elements of the mental health team. I think it's go more than that. When I'm thinking of cases, sometimes I think like a puzzle, and I think that we all kind of are one piece of the puzzle. So nurses, doctors, therapists, health assistants, that sometimes they are the ones who spend more time with the patients and helping them with the basic activities. Other professions of health, like in this case, not just when we are working, we cannot separate mental health from an organic disease because we just have one person. So I think we need to have a close articulation between the other doctors and the other specialties, not just the psychiatric. And you might ask, we are in 2018, why am I talking about the case of 2014? Okay, because the diagnosis of X-fragile syndrome, the report just came to us after I left the hospital. And I think a person with mental health issues, it's not just psychiatric symptoms, and everything is a factor for our well-being and for our mental health. And at last but not least, the patient and the family. Like every piece of the puzzle matter. And I think if we work on this way, we can try to reach to an open dialogue for us to hear each other. Okay. I just would like to thank Dr. Paula Duarte. She's the team coordination of the Day Hospital of Psychiatry of Hospital Egas do Centro Hospitalar de Lisboa Ocidental, because she was the one to push me forward to write and to present this case and help in the construction of the case study. It's my bibliography, and thank you very much for your attention.